Hello, everybody. You already know what this series is. Today, we are zooming into 61 and getting started on NBME 27, everything you need to know by the time you take this exam. Of course, these questions are my own. Let's dive into it. A 14-year-old African-American boy has a history of homozygous sickle cell anemia. We know that this is a GLU6 valine substitution on your mutation of your beta globin gene. And which of the following is explaining the therapeutic effect of his treatment? Well, he started a new medication, and he has not had any transfusions. And so this new medication is going to be hydroxyurea. Now, hydroxyurea increases your fetal hemoglobin because in sickle cell disease, you have the polymerization of your HbS under hypoxic conditions, your HbS right here. So the mechanism is that we have the increased HbF production, which prevents that sickling. And our side effect is that we have bone marrow suppression, so neutropenia, thrombocytopenia. But what happens is this HbF binds oxygen really strongly, and that will shield the HbS from deoxygenated environments. So it's the hero is our HbF, our fetal hemoglobin, because it's super binding. It binds that O2. That'll prevent complications like stroke, ACS, or splenic infarction. And so our answer is going to be increased hemoglobin F production. Why? Because the reasoning is, as you can see here, hydroxyurea is going to increase your HbF, and that stops the polymerization, and then it stops those vaso-occlusive crises. The other answers are wrong because hydroxyurea is myelosuppressive, but it does not target your EPO. Increased 2,3, that would promote the deoxygenation of the curve. So that's not our answer. Decreased membrane permeability, not associated at all with hydroxyurea mechanism, and it does not involve the cytokines. And so boosting that baby protein is the key to treating the adult pain. Our goal is to prevent that hemolysis and those painful vaso-occlusive crises. Hemoglobin S, the sickle variant, it polymerizes whenever it's deoxygenated, and that causes your red blood cells to kind of sickle and now clog the vessels, and it hurts. It causes ischemia. And so hydroxyurea is a drug that rewires the red cell production. It increases the fetal hemoglobin, HbF, and that's the form of hemoglobin that binds oxygen tightly and does not participate in the sickling process. So the more HbF you have, the less that the HbS will polymerize. And so you have fewer crises, you don't need transfusion as much, and you have longer life. This next question is going to be super classic. This is known as fetal alcohol syndrome, the most common preventable cause of intellectual disability in the United States. It's when alcohol crosses the placenta and it disrupts the brain development. So they're born with microcephaly. They also have growth delay, and there's also the distinctive feature of the smooth philtrum, the thin upper lip, and the small eye openings. They can have cleft palate, heart defects, and serious learning behaviors. So we have our girl, small head, thin upper lip, smooth philtrum, widely spaced eyes, definitely going to be alcohol. Isotriate that causes craniofacial and cardiac abnormalities, but not this triad. It's not going to be anything else. Like another answer could have been cocaine. Well, that would cause vasoconstriction and growth restriction, but not facial problems. Here are the trap answers why they're wrong. Phenytoin, nail hypoplasia, limb defects, cleft palate will be phenytoin. You don't see that smooth philtrum ADHD pattern. Warfarin, stifling the epiphysis, nasal hypoplasia. Valproic acid has neural tube defects like spina bifida. Other answers they could have given you like heroin. That would be seen in neonatal abstinence syndrome. But yeah, that smooth philtrum is kind of a giveaway there. For this one, we're going to talk about standard deviations. There's this thing called the 68, 95, 99.7 rule. So the 68, that's within one standard deviation. 95 is in 2 standard deviations. And then 99.7 is 3 standard deviations. So here is our practice question. A researcher analyzes the blood glucose of 200 obese adults, and we have a mean of 112 with a standard deviation of 10. And assuming normal distribution, how many participants are expected to have fasting glucose between 122 and 132? Well, 112, that means like right here is our 112, and 1 standard deviation over here would be 122, and then 2 would be 132. So that's our 122 right here, that's 1 standard deviation, and this is 2 standard deviations. So basically it's asking what's falling between these 2 standard deviations. And then we know that there are 200 adults, so 13.5 of 200 is about 27 people. And that's our answer. So there's our breakdown, but if we were asking about the 2 to 3, so that's going to be our 132 to 142, then to be an even smaller distribution, only 2.35%, and that would be rounded up to 2. For a sample size of 100 people, but we have 200 people, so you double that and it's 4. Basically, what we need to remember is that 68% of the population falls between the first standard deviation, 95 falls in the second, and 99.7 falls in the third. If you want to find what's in between these particular units, then you have to subtract them. And also remember that you're on the upper echelon here, and so there's only going to be half of them on this side of the normalized curve. Okay, moving on to 64. So this guy right here is a sulfonylurea. They close potassium channels in pancreatic beta cells. That causes depolarization, calcium influx, and insulin release, and hypoglycemia. So this is what happens after the insulin is released. It doesn't explain the drug's mechanism, A. And in case we need a refresher of our diabetic drugs, we have biguanides, that's like metformin. And those work by decreasing the hepatic gluconeogenesis and they increase insulin sensitivity. That's first line for diabetes type 2, but you have a risk of lactic acidosis. Then you have your sulfonylureas, and these guys increase endogenous insulin secretion. They close the potassium channels in the beta cells. So the risk is mild hypoglycemia and postprandial control. And there are GLP-1s, the receptor agonists. These are like the leptins, saxagliptin, ningaliptin. And the mechanism there is they obviously inhibit DDP4 enzymes, which increases endogenous GLP-1, then cause nasopharyngitis, and then SGL2. The SGLT2 inhibitors like singaflosin, alflosin because it flows in the urine, and they block glucose reabsorption to cause the glucose to flows in the urine. The risk is UTIs and yeast infections. And last, we have our TZDs, like the glitazones. And these guys bind your PPAR gammas because they're at a party. The glitter at the party binds the PPAR gamma, increasing insulin sensitivity, weight gain, edema, seen, chronic heart failure. And alpha glucosidase, like carbose, those inhibit intestinal brush border enzymes, causing decreased carb absorption. And there are amylin analogs as well. Those decrease glucagon release. Of course, you can also just give exogenous insulin. Those are rapid. Lispro, Aspart, Glulazine. Short-acting is just your regular insulin. Long-acting is Glargine, Detamir, Degludec. And these are used in type 1, type 2, and gestational diabetes. The risk is hypoglycemia. So the first line for T2DM is metformin. If you're giving GLPs and DPP4s, then you should watch for pancreatitis. But sulfonylureas usually present with the hypoglycemia. It's the most common presentation that you'll see on test day. GLP-1s and SGLT2s cause weight loss, and the TZDs cause weight gain. So our answer is a closure of these sensitive potassium channels, because sulfonylureas close the potassium channels, causing depolarization, calcium influx, and insulin release. B would be metformin's job, the inhibition of hepatic gluconeogenesis. It's metformin. Blockade here would be a carbose, and this is glucose excretion. When they mention C-Peptide, it's important to note that C-Peptide is a byproduct of endogenous production. So when proinsulin is cleaved in the pancreatic beta cells, then it produces insulin and C-Peptide. Insulin's active and C-Peptide is inert, but you can measure it. And they're secreted in equal amounts. And so you can distinguish between endogenous insulin, which causes the C-Peptide to be present, and exogenous, in which case it's low. So in factitious hypoglycemia, you give insulin injections, and so you have low C-Peptide. In a sulfonylurea overdose, you have high C-Peptide. So that's the difference. In insulinomas, you'd have increased C-Peptide. In Whipple's triad, you'd have hypoglycemia, low plasma, glucose, and relief after glucose is given. In type 1, you have low C-Peptide, and in type 2, give insulin, and you can also have high C-Peptide in type 2, but you have insulin resistance. So C-Peptide just means it comes from endogenous insulin, and no C-Peptide means it came from like a needle. So yeah, that medication, the glimepiride, is going to increase the pancreas secretions of insulin, even though it's already low. That's what sulfonylureas do. Okay, next we're going to talk about rejection, something that I have ample familiarity with. You have your class 1 MHC molecules, the recognition of your CD8 T cells, that's going to be acute rejection. Or you could have your class 2 with the CD4, and that's chronic. So in this practice question, we have a 52-year-old woman undergoing liver transplant. 2 months earlier, her liver enzymes began to rise despite normal imaging. Biopsy of the graft shows mononuclear infiltration of the portal, tracks with CD8 positive T cells, and endothelitis. What's the most likely immune mechanism responsible? Well, CD8 positives, and so it's going to be the class 1 molecules. Now, if we have a recent transplant and we see a lymphocytic infiltration of the small vessels, that should make us think of this mechanism where the donor kidney expresses MHC class 1 molecules on its tubules, its endothelium, and then the host, CD8, is like, hey, these are foreign, and that causes a cytotoxic T cell activation, and it releases perforin and also granzyme B, and that causes cell lysis and graft dysfunction. So this occurs within weeks or months of post-transplant, and this can cause chronic if it's not treated. So you're going to see a rise in creatinine levels with a normal physical exam within 6 months, and you treat this with high-dose corticosteroids and T-cell depleting agents, but you have to rule out infections like BK virus, CMV, because this can mimic rejection. So this is acute rejection. It's not the host bodies against the donor HLAs, that's antibody-mediated rejection. It's not complement from preformed antibodies, that'd be hyperacute. It's not natural killer cells, because those guys recognize MHC-lacking cells, which is not the case. So rising creatinine after a while can mean a lot of things, but if it's a month later and the biopsy shows lymphocytes, then you should think about T-cell-mediated rejection. It's a type 4 hypersensitivity, and if it's untreated, then it can destroy the graft. All right, next is super simple. It's just about sleep hygiene. If you're trying to get up early, then what you should do is just make sure that you get up at the same time every single day, even if you don't get much sleep. And then after a while, your circadian rhythms will kick in. All right, for 67, we We have a 2-year-old girl with multiple episodes of cellulitis and omphalitis. Since her birth, the umbilical cord fell off 45 days later after she was born. She's got yellow crusting, no leukocyte count is 32K. The absence CD18 tells you it's an LFA1 integrin deficiency. And we'll talk about what that means. This is autosomal recessive inheritance. So there's this thing called the LFA1 integrin complex that's essential for firm adhesion, and the CD18 is part of that. So normal phagocytosis and killing occurs once at the infection site, but it can't get there. That's the problem. You just can't migrate. And so you might see impetigo, which is just a contagious bacteria skin infection that forms pustules and yellow crusty stuff. Poor wound healing, elevated neutrophils, but it's absent in the tissue. That's the very important part. It's elevated in the blood, but absent in the tissue. So the pathophys of this is that the leukocytes, especially the neutrophils, must exit the bloodstream during inflammation. And normally, we all know this, there are paths that you have to follow. It's margination, and then there's rolling with our select. Then we have adhesion, and that adhesion occurs with integrins like CD18 and LFA1. And then transmigration, which is diabetes. So in LAD, you have a defective CD18, so the leukocytes cannot adhere. So they can't migrate out. It's going to be this step right there. And so tons of white blood cells are stuck in the bloodstream and none at the site of the infection. So there's no neutrophils. That means there's no pus. That's the reason why there's no pus. So they'll have recurrent infections like Staph aureus, Strep pyogenes. There's no leukocyte or pus in the gram stain. There's a mutation in the CD18. There's increased neutrophils, but they just can't do anything, can't go to the tissue. And there's delayed umbilical separation. Now, we'll try to trap you with all sorts of stuff for a question like this. They might even mention IL-17, and that is seen in mucocutaneous candidiasis, not staph infections. They might give you something weird like, CD40 ligand. And CD40 ligand is seen in hyper-IgM syndrome that causes impaired class switching. They could give you something like NADPH oxidase, and that's chronic granulomatous disease, where the neutrophils reach the infection, but they just can't kill it. That would be your NADPH oxidase deficiency. So it's not that. It's not impaired class switching. It's not IL-17 because it's not mucocutaneous candidiasis. They might even give you some of this interesting VDJ recombination stuff. Don't be fooled. That's seen in SCID, where the adaptive immunity is broadly defective. So you see a child on test day of recurrent skin infections, no pus, super high neutrophil count. Think of leukocyte adhesion deficiency. They got a problem with CD18, and that allows the white blood cells to stick to the endothelium and migrate. But without the CD18, the cells can't exit the blood vessels, and so they just pile up there. So that's why you don't see the pus. So next time you see a clean, pusless bacterial lesion on a toddler with high white blood cells, then it's going to be impaired migration. That's CD18 damage. And it's the transmigration through the vascular endothelium. It's not activation. We'll go through these answer choices. The neutrophils still respond. They just can't reach it. It's migration. It's not ROS. That's chronic granulomatous. It's not phagocytosis. I think it's still phagocytosis. They just can't get there. All right, 68. So here we have a 33-year-old female. She's intubated following a traumatic brain injury. When stabilizing ICU, lowers her respiratory rate from 18 to 8. Which of the following physiological effects would this change? The answer is the intracranial pressure. Here's a common question. Would vasodilation decrease ICP? The answer is no. Vasodilation increases it because you think of ICP as the brain tissue plus the blood volume plus the CSF. The skull has a fixed volume, and if any of those increases, then the ICP goes up. And so CO2 causes vasodilation, and that's the big thing to know. CO2, vasodilation, it's all over these exams for some reason. And so there's more intravascular volume, and so the volume causes the increased pressure. And so hyperventilation decreases CO2. Is a treatment for it. Causes vasoconstriction, reducing ICP. Next, we're covering an interesting mechanism for 69. So capsaicin, how this works is it activates TRPV1 receptors. Those triggers release, then deplete substance P from the peripheral nociceptors. It's used in neuropathic pain. And so we have the inability to feel pain. So it's a topical depleting substance P used for diabetic, post-therapeutic, and localized neuropathic pain. Initial burning is a side effect. All right, there's our practice question. We got a woman, long-standing type 2 diabetes. She was prescribed topical medication that caused a burning sensation, but then it reduced the pain. What's depleting? It depletes substance P, which is a neuropeptide that's needed for pain transmission. So pain sensation is released from the nociceptive C fibers, and they act on the dorsal horn of the spinal cord and facilitates pain transmission to the brain. So burning, aching, slow pain, stuff like that. Substance P increases the vascular permeability and promotes mast cell degranulation, resulting in edema, redness, swelling. Elevated substance P can also be linked to depression, stress, and anxiety. And so it's targeted in mood disorders treatments. So that's a big part of how we feel the pain. The answer is substance P. These guys are targeted by NSAIDs. Bradykinin is involved in vasodilation and angioedema. This is a mediator of your allergies. All right, question 70. We have a 6-year-old girl evaluated for persistent short stature, small, remained below 5 percentile, parents are average height. There's uniparental maternal heterodisomy at chromosome 7. What explains it? Answer is a loss of paternally expressed growth genes due to imprinting. So there's a paternal copy of a gene that is the only active one. And so if both chromosome 7s come from the mom, so you have paternal imprinting for Angelman and maternal imprinting for Prader-Willi. So uniparental disomy is when both copies of chromosome come from one parent only. And why this is interesting is you can have a completely normal set of genes, but if they only come from one parent, you can still have a genetic disorder. That's uniparental disomy. Both chromosomes come from just one parent. And so you might see a question where they have, I don't know, like a boy with maternal heterodisomy of chromosome 7. That means both copies of chromosome 7 came from mom and none came from dad. And there are some genes in chromosome 7 that are normally expressed only from paternal. And so the maternal copy is silenced through methylation, and that's a process called genomic imprinting. So even though the genes are structurally intact, they're effectively just shut off. And that leads to growth failure, like in Silver-Russell syndrome. So this is really just epigenetics. All right, it's not trinucleotide. That'd be Fragile X, Huntington's, and those things. Autosomal dominant, family history would be different. Somatic, patchy asymmetric findings, and tumor suppression, it's just cancer. All right, folks, we have finished the next 10. If you found this helpful, like and subscribe. We'll be continuing this series. We'll see you in the next video.